Good evening daw.
Welcome to sit down. So, hi, may I know your name?
I'm Mr. Marco Paulo.
Mr. Marco Paulo, I am your physician for today. I am Dr. Ana Reyes. So, we will be performing cardiovascular examination on you. And before we start, I just have some questions. Okay? So, first, how are you feeling today?
So, I'm fine.
Okay. So, have you experienced any chest pain before? How about any palpitations lately?
Wala.
How about shortness of breath? Wala din. So, okay. So, to examine you, we would require you to take off your shirt. Would you be comfortable doing that? So, okay. So, please take off your shirt and please wear the lab coat. Cardiovascular examination includes the examination of the jugular venous pressure, carotid pulse, and the inspection, palpation, and auscultation of the heart. So we will begin with the jugular venous pressure. The jugular venous pressure is the measurement of the elevation of the highest oscillation point of the jugular venous pressure. So it reflects the central venous pressure, and it is important to know, it is important in knowing the intravascular status of a patient, especially those with euvolumic, hypovolumic, and hypervolumic patients. So we will start with our inspection now. Sir, can you please lie down?
Sige.
Sir, would it be okay if I'm going to take up the upper portion of your blood count? So, to begin with, we would first locate the landmark, which is the sternomastoid muscle, which is here around the neck. Sir, can you kindly turn your head to the left? Okay. So here, we're going to look for the external jugular vein. So the external jugular vein can be found at the sternomastoid muscle, and underneath it, you can palpate for the internal jugular vein. So we're going to palpate. Okay. After that, we're going to take a cardboard paper and a ruler to measure the meniscus. So first, look for the pulsation. Okay. And then measure the vertical distance from the sternum. So the jugular venous pressure of our patient is measured at 2 centimeters above from the sternal angle. So that measurement is normal, and a measurement of above 3 to 4 centimeters is considered abnormal.
Good afternoon, sir. I am Dr. Adele, and I will be examining your carotid pulse. Carotid pulse provides cardiac information and is useful for aortic valve stenosis and aortic insufficiency. Unlike the jugular vein, it is more stable because it is not affected in relation to position and inspiration. So palpate for the carotid artery located at the lower third of the neck inside the medial border of the cricoid cartilage. So the patient's carotid pulsation upstroke is smooth and brisk, and its summit is smooth and rounded. Its downward stroke is less abrupt than its upward stroke. Also, auscultate for the carotid artery and check for bruits. Bruits is the presence of rushing, murmuring sound other than its cardiac origin. Presence of bruits means arterial narrowing. So the patient has no bruits.
So good afternoon, Mr. Marco. I am J.D. Sales and I will be your physician for today. Is it okay if I will begin the examination? First, I will be inspecting your chest. There are no heaves and leaves noted. Next is I will palpate for the sternum. Next is the second and third right intercostal space. Second and third left intercostal space. And for the apical border. Next is palpate for the trials using the ball of the palms on the same location. So for the sternum, second and third right intercostal space, second and third left intercostal space, and for the apical border. Next is palpate for the apical impulse. Apical impulse represents the early pulsation of the left ventricle as it moves anteriorly for contraction. It is also known as the point of maximum impulse. If you can feel or palpate the impulse, ask the patient to lie on the left side and exhale fully and hold his breath. Please return. Again, palpate for the apical impulse. Next is measure the distance from the mid-sternal line. And measure the diameter of impulse. The patient's apical impulse is located at the 5th intercostal space, left mid-clavicular line, 8 cm away from the mid-sternal line. Its amplitude is recorded as strong with a diameter of 1.5 cm. Next is palpate for the ventricular impulse. It is located on the 3rd, 4th, and 5th intercostal space and palpate for the epigastric area. The patient's ventricular impulse rhythm is normal and the amplitude is strong.
Sir Marco. I am Renaldo Hermosa. I'll be your attending physician for today. So there are two heart sounds, S1 and S2. S1 is the closure of the mitral valve, S2 is the closure of the aortic valve. Systole is heard in between S1 and S2, while diastole is heard in between S2 and the beginning of S1. These heart sounds are best heard using the diaphragm of the stethoscope. The S3 and the S4 are heard on the early and late diastole. These are best heard using the bell of the stethoscope. Okay. Sir, may I start my examination? To auscultate for the S1 and S2, place the diaphragm at the right second intercostal space for the aortic area, and then the left second intercostal space for the pulmonic area, which you can also auscultate at the left third intercostal space. For the left fourth intercostal space for the tricuspid area, left fifth intercostal space for the mitral area, and the apex for the apical beat. Use the bell to auscultate the left fourth intercostal space, left fifth intercostal space, and the apex. Going back to the aortic area, note for the cardiac rate and rhythm. Okay. The patient has a good S1 and S2. There were no murmurs and other heart sounds noted. The patient has a cardiac rate of 65 beats per minute with regular rhythm. Okay, Sir Marco, you can now change with units.
There are two types of murmurs, the systolic and diastolic murmur. The systolic murmur can be classified into mid-systolic and a parasystolic murmur. The mid-systolic murmur starts after S1 and ends after S2. The parasystolic murmur, on the other hand, begins with S1 and stops at S2. The diastolic murmur can be classified into early, mid, and late diastolic murmur. There are 7 attributes that describe murmurs. The first is the timing, which was described earlier. The second is the shape. It can be classified as crescendo if it's getting louder, decrescendo if it's getting softer, crescendo and decrescendo if it's rising then falling, plateau if the intensity is consistent, and the third attribute is the location, which can describe where in the specific intercostal space the murmur can be heard and its distance from the sternum and the apex. The fourth, fifth, sixth, and seventh attributes will be discussed further by John.
The fourth attribute is the radiation of the murmur. Describe the intensity of the murmur and the direction of blood flow. Next is to describe the intensity of the murmur using the 6-point grade. 1 being the high, being the faint, and 6 being the loudest with palpable fill. The intensity will depend on the thickness of the wall and the intervening tissues. Sixth attribute is the pitch that can be described as high, medium, or low. The next is the quality, which can be described as harsh, blowing, and rumbling. So for example, to describe for aortic stenosis, the grade could be 2/6 with harsh decrescendo with mid-systolic ejection murmur, best heard at the second right intercostal space.
Today, we will assess the peripheral vascular system. First, we must know the health history of the patient and ask concerning symptoms relating to the peripheral vascular system, which includes abdominal pain, back pain, pain on the arms and legs, intermittent claudication, which is a pain or cramps of the legs during exertion, but it is relieved within 10 minutes.
Also, common symptoms like cold, numbness, pallor in the legs, hair loss in the extremities, swelling in calves, legs, or feet, color change in fingertips or toenails during cold weather, and swelling with tenderness and redness are also related to the peripheral vascular system. Following the history taking of the patient, we will now briefly discuss the anatomy of the peripheral vascular system.